You say, ha, it's working. How dare you doubt my technology prowess. Brilliant. Let us begin. All right, cool. Hip, right? So what we've done is we've taken our time to go through the process of thigh down, because I felt that the complexity within the hip to begin there is something that tends to be a touch traumatic. Yay, trauma. Okay, so things get a little bit more involved. Hip, how many degrees of freedom?
3.
3, good, I like it. We have 3. Why do we have 3? What can we do with it? Flexion, extension, and we did both of those referencing part of it when we dealt with thigh musculature, right? So we have to add a couple muscles into that because there's obviously just hip stuff, not just 2 joint over the knee. So, flexion, extension, brilliant. What plane is that?
Sagittal.
Sagittal, good. What's next? What else can we do? Put your right foot in, put your right foot up, put your right foot in, shake your bum. What motions are involved, right? Flexion, extension, what else? Abduction, adduction, abduction, adduction. And what's our last? Oh, what plane is that? Frontal plane. That means what's left? Rotation. Transverse plane. Okay? Good to go. So, what do we have with this is, well, we're getting to the point that we're taking all of your upper body weight, transferring it through your spine, which we'll get to next, and then we're splitting that load bilaterally, splitting it sideways into 2 legs so that we can ambulate, we can walk, we can move our happy selves around. Good? Awesome. So in the process here, we have 2 joints that the hip is really kind of creating. So the hip is taking both an articulation of the spine into the pelvic bone, and then we're taking that pelvic bone and transferring that into the femurs laterally. So we'll start with one of the femurs. So we've looked at the femur all by its lonesome, all by itself. We've done quite a bit of that. We get into, so we have the head with the greater trochanter, which is the outside edge of your hip right in through here. There's a lesser tubercle trochanter down in here. And then we have a neck that comes up. So the first thing that I want to kind of focus on is, okay, what type of joint? Ball and socket. Grab one of those femurs. So look at the head of the femur. So nice big rounded surface that's got a big old dent in the front of it. Rotate it. There you go. Boom. It's a big old dent called a fovea. So right in the center of that ball, we have this nice little notch taken out. There's actually a foveal artery that runs through the pelvis into the head of the femur. So it has its own blood supply from inside the joint itself. Fovea, F-O-V-E-A. Fovea means hole, but a foveal artery. But that is the fovea. That is the dent, the notch, the nook.
Is that a landmark we're going to use?
Yeah, probably. Good to know that you have a blood supply going directly into the head of the femur. You look at dislocations. We start looking at necrosis. So there's avascular necrosis, slip capitofemoral syndrome. There's all kinds of random stuff with the head of the femur that can affect kids or otherwise. So yeah, there's a unique component to that, having an artery that runs straight through that joint like that. Something to consider. Now, we don't have a lot of ligaments to tie in with the hip itself. We have this lovely blue that's been highlighted here for us. It's the joint capsule. Now, the joint capsule is, well, a series of ligaments that kind of wrap around it. So we can break those down into three main parts, and those three main parts are really simple to remember. And the reason for that is because it's named by the part of the bone it comes off of. So I guess that means I should back up and say the pelvic bone is actually three different bones fused together. So what are those three bones? The ilium, the pubis, and the ischium. Good? So the ligaments that we're going to have when we work on this is iliofemoral, pubifemoral, ischiofemoral. That's it. Nothing rocket science level. Nice and easy. So we have a pretty good stabilization of all of these, of the hip itself, from these bandings and ligaments. Now the pelvis, beyond that, it's those three bones fused, but in two separate bones. And they kind of create a bowl that carry stuff, soft, squishy stuff. So you've got GI tract, urinary tract, reproductive organs, stuff. It cradles all of that underneath it. There's a whole series of muscles that stabilize called the pelvic floor. There's small muscles that help you control when you pee. They control sphincter openings. We're going to glaze on that because it kind of gets out of the realm of what I need to know. When you go to PT school, they can all that stuff in your brain all they want to. So we will focus on motions of the hip as we go through that. So key terms that we want to kind of focus on. Ramus. We're good with that word now? What is it referencing? What part of this? Yep. That. As you massage it. So, this section right down through here, right? So the ramus, kind of the arms that kind of wrap around, creates kind of a hole. So the pubic bone, as it comes up in the ischium, and it meets up in with that iliac crest, up iliac bone up and through here, creates that pubic ramus. What is that hole called? Foramen. Foramen means hole. So what hole is it? Obturator. If you want it spelled, I can give it to you. There you go. Obturator membrane covers the obturator foramen. So it's a hole. You'll see that name, you need to remember it. It's a nerve, it's muscles, it's a hole, it's a membrane. And once again, it's a word I haven't quite looked up yet. So I don't know if it means flatworms, kind of like lumberjacks, whatever. Anyway, probably not. All right. To stabilize said bowl. Again, we have two winged kind of half-cocked bowls that come together. They give us the anchor point to create your hip. Above and beyond that, to stabilize this, we have this piece right here in the middle. So there's a cartilaginous disc that sits right in between the two rami, right in the middle, that helps stabilize and put these things together. And it does. It gives, it shifts, it moves. It allows it to have a little bit of motion. Called your pubic symphysis. Definitely something that we can cause injury to because there's an irritation and inflammation of that area. People who tend to let a lot of rotation in their play, in their movement, soccer players, sometimes tennis players, where they have a lot of torque at the pelvis that causes those two bones to kind of shift off of each other. You can find it. So if you basically find your belt, where it would close right here, it's just below, like a finger width. You can feel that. So it's well above any kind of sensitive organs, where pretty much your belt goes here, and then right underneath is that junction of your pubic bone as it wraps in and around. So it's high and definitely very powerful. All right, so past that, we have a series of ligaments that we want to four main ligaments that we want to look at that reinforce and stabilize this bowl. So one's right here, here, here. So the inguinal ligaments first. There. Good. So if you find your ASIS, anterior superior iliac spine, and then again you find that pubic symphysis, that line between the two, pushing right here across there, so pubic symphysis, ASIS, coming right across, and you're pushing right down on the inguinal ligament. So it does a couple things. It's going, again, from the pubis, bless you, from the pubis out to the ilium. So it's spanning, again, two bones, even though the pelvic bone is one bone, but from the two fused. So it gives us a little bit of a splinting structure, a tether, to help hold those two in, to pull them together. But it also creates a roof, because this is an exit passageway for some structures. If I go overlay a little bit of tissue, what do I want to give you? I want to give you that one, and I want to give you that one. Then immediately you see A, you're like, oh my gosh, there's so much stuff. Yeah, there's a lot of blood supply in there, there's a lot of nerves running through there. But you'll see that two major, an artery and nerve, and a vein kind of pop right underneath it. So this is a rigid protection for that location as well. So we're going to get into the femoral triangle, which is kind of how to identify this space right in through here for the sake of finding that. And we'll do that once we get into the muscles, because you'll need to see that. But this inguinal ligament is going to be one border of that femoral triangle. We'll make it all look simple again. How's that? Good? Good. Okay. So, next, we're going to jump up top. Iliolumbar ligaments. So, from the ilium, we have the anterior part is going to be stabilized by the inguinal ligament. And then we're going to go and take the iliac wing, crest, and anchor that in to L4 and L5 transverse process. So, lumbar vertebra, L4, and lumbar vertebra L5, and it's their transverse process that helps stabilize the pelvis and staying anchored to the distal lumbar spine. Okay. From there, we're going to have stabilization again from the ilium down to the ischium. We're going to go there first. Oops, that's supposed to be sacral there. Sorry, we're going to go there. Sacrotuberous ligament. So from the sacrum down into the ischium is your sacrotuberous ligament. You can actually feel this on palpation. If you find your sit bone, your ischial tuberosity, and you come superior a little bit, you can actually find what feels like a bone on yourself a little bit higher up. So right where the crease is, and you find ischial tuberosity, and you go a little higher up and in. I'll let you palpate yourself on this one. But you can feel what feels like a bone, but it's a very, very strong, thick, rigid banding. It's called the sacrotuberous ligament. That's my last guy right there, sacrospinous. So sacrum over to the spine of the ischium, the ischial spine. So the better you know the landmarks, the easier it is to remember kind of where these things are going. Sacrotuberosity, sacrotuberous ligament, go from the sacrum to the ischial tuberosity. Sacrospinous, sacrum to the spine of the ischium. Circle enough? So we're not trying to be tricky. Inguinal. Now, inguinal becomes important when you start looking at hernias. Bless you. Because where we have this passage and you have that opening for the artery to come through, if that hole gets open a little bit, you can have small intestine kind of slip through, which hernia is an opening that shouldn't be there, a hole that shouldn't be there. I think you left your first coffee in my office. So, is that hole so that the small intestine can actually slip through and get strangulated there, which is going to be pretty problematic. But on palpation and from your pubic symphysis, from your ASIS, that pathway, if you get a lump right there, so it kind of feels like something's pushing it forward, it's usually that something has slipped through that hole and it's pushing that ligament anteriorly. Usually pretty tender. Pretty quick surgery, they can just go in and put a mesh to cover the hole, and you'll be back up and about pretty quickly, relatively speaking. So, 4 main ligaments that stabilize that pelvic rim. Good to go? Great. So, stepping back up, we have another pair where we're looking at where that pelvis bone, the pubic bone, the pelvis wraps in and around to the sacrum. And we get a pair of joints called your sacroiliac joints. So the iliac wing, the iliac crest, the iliac bone is blending, is combining into your sacrum. So find me a sacrum. And you'll see the ala, the wings of the sacrum running through here. But this is an articular surface for the pelvis then to kind of wrap out and around. So it's pretty broad. It's a pretty large anchor point. If you find another pelvis, and you can see again on it, is this very rough area that it gives us the capacity to articulate. Oops, like that. Good. Now, this joint here, this SI joint, sacroiliac joint, it doesn't move a whole lot. It's pretty anchored down between the broad surface that are the wings, the ala, and then the ligaments that span across it both anterior and posteriorly. It's pretty locked. I mean, it's taking our body weight and allowing transfer left and right. And you'll see issues with individuals where that joint doesn't have, it only has about 1 to 2 degrees of motion. Not degrees of freedom, but degrees of motion. So it rocks just ever so slightly. But if it gets stuck, if it gets locked up, then all of a sudden you're going to have some pretty unique problems and issues. So you should talk about SI joint issues within ortho. You guys remember way back then. It was like so long ago. But failure for that joint to give and rotate the way it should is going to give us some issues in terms of pelvic tilt rotation, to where your whole pelvis might torque, to where one is tipping forward and the other one's tipping backwards, and then nothing's working right. All right, so stabilizing ligaments. For that, we have an anterior sacroiliac ligament. Yay for hard things to remember. And in the back, we have an upper and lower posterior sacroiliac ligament. There's a whole lot of structure in there to stabilize those joints. It's got quite a bit of load going through it. All right. So joints, alignment. There's some unique components at the hip and with the pelvis in general and tilting that we want to pay attention to in doing a posture assessment, to kind of know how somebody's Legos are put together. So the base term we're going to work with is coxa, C-O-X-A. And then we're going to have coxa norma, which is normal. And then coxa vara and coxa valgus. Vara, V-A-R-A, valgus, V-A-L-G-U-S. So the angle that's created from the head through the neck to the shaft of the femur. So from the head through the neck down the shaft is an angle we're somewhat concerned about. Conveniently called the femoral neck angle. In a normal adult, it's about 126 degrees. More legible. It's possible to have an angle that is significantly less. So a smaller degree angle is going to give me coxa vara. A larger angle towards more vertical is going to be coxa valgus, coxa valga.
Where's the smaller angle is possible.
Yeah. So smaller angle, like that closer to 90 degrees, coxa vara. Bigger angle, coxa valga. So if we zoom out a little bit, we start looking at posture assessments. The term for the knee, remember articularis genu, G-E-N-U, is referencing the knee. Coxa is referencing the hip. You can have genu valgum to where the knees are knocking in. You can have genu varum. Just kidding. So the knees are bowing out. Genu varum is bow-leggedness. Genu valgum is knock knee. Okay. If I have a more narrow angle, which is what? Coxa what? The femoral neck angle is, so coxa vara, right? Then that is going to create or be typically associated with genu valgum. So coxa vara, looking at the femoral neck angle, genu valgum tend to run together. So how does that work? If you stand and you have a more narrow angle here, that's going to pull your femur inward because it's a smaller, narrower angle. And that means it's going to drop your knee in more, which is going to lead, so that's coxa vara, giving me genu valgum, knocking my knees together. If I have a wider angle, coxa valga, then that's going to bring my knees out, which is going to give me genu varum. So they're opposites. Good to go? These things kind of have implications as you start looking at people's body function. If I have a more narrow angle, so my coxa vara, I have a more narrow angle, then the body load that I have up here that's transitioned downward as it's split sideways to run down bilaterally, it puts more stress right over the neck of the femur. So it increases my likelihood of having stress fractures through the neck of my femur. It increases the stress. Because what kind of bone was making up the inside of the neck of the femur? What are my options of bone types? Hard, which is, what's the fancy name? Hard versus spongy. So what are my real names? Cortical and another one. Big funky name, trabecular. Right? So trabecular bone, it's like, I don't know. Okay, so trabecular bone is the spongy bone, the inside that kind of creates the strut work internal. Cortical bone is that dense osteons driving through that give me resistance against compressive force. Well, at this point, most of this bone through here is made up of trabecular bone. So it's a whole lot better at handling curves than it is strict angles. So it's just not as strong. So to have that spongy bone through the neck of that femur means that it's just a weak point within the individual. Is that saying that they can't play sports or anything? It just means that they're probably at a higher risk. Good stuff so far? Okay, so here's what I want. Take a few minutes, roll out some clay. Build the ligaments that stabilize the pelvic rim. We've got the joint capsule itself. Reinforce that it's coming from the three main bones that fuse to make up the pelvic bone. So pubis, iliac, ischium. So pubofemoral, ischiofemoral, iliofemoral. And then we've got the four main ligaments that help kind of function as strut work to keep that curvature and stabilize from kind of major landmarks. Sacrotuberous, sacrospinous. Those are referencing landmarks on the ischium. So ischial tuberosity and ischial spine. Iliolumbar and inguinal. So be friendly, make yourself some cords, and go figure out what they look like and where their attachment points are.
Oh, you're doing it? Yeah. I'll do this little one to get out there. Cool. But it'll hit me a little bit.
The greater is considered the false. So if I look down from kind of above, you'll see that we have this nice little almost circular opening found by the walls of the pubes of the pubic rami into the sacrum itself. So that's the lesser, that's the true. It's defined all the way around, which is why they reference it as true. This is going to get into more urogenital soft tissue. The greater is this upper rim. And you'll notice that the anterior, from about the midpoints through the rest of the anterior from looking up from the upside isn't complete. So that's one reason it's called the false. So it's more of the posterior walls that help support the soft tissue, the GI tract, the large and small intestine. Now, we have an articulation point here at your SI joint. We have another articulation point mirroring that on the other side, so right and left SI. And then we have this pubic symphysis. So we have two separate bones that have the degree of mobility. So there's all sorts of kind of funny little combinations of things that we can do to ourselves with this. If I measure, so we have PSIS. What does PSIS stand for? Posterior superior iliac spine. Okay? Right here. Posterior superior iliac spine. And then we have your ASIS, anterior superior iliac spine. If I run a line from one to the other, and I compare that to the horizontal, and I can get a measure of tilt in the pelvis. So, and this is how I teach a lot of people to start working on their core control, their core abs. So everybody stand up for a second. You're not doing much. The trauma and the soreness in the way.
She's just a complainer.
I'm catching that. Alright, so you can stand here, and when I focus on people learning how to use core activation, the core musculature stabilizes the pelvis. It anchors the upper body to the pelvis, from which we have all these motions we need to have at the hip. So this has to be anchored. We start seeing quite a few issues if this isn't. And there's a lot of people that don't quite know how to functionally control their core. Okay? So, to get those muscles to work, I want to focus on what this pelvic tilt really means. So the best way that everybody kind of figures out is to use your lumbar muscles. And the way to do that is to give yourself a big old booty. So you're going to anteriorly tilt that pelvis, which is going to kind of pronounce the backside. Doesn't feel very comfortable to me. It increases a lot of stress on my lumbar spine, which I'm not a big fan of. But what I want is to go the opposite direction, to give me a little bit of a posterior tilt. And that's called, we reference that as flat back. Because it's pulling that space, that gap that you're getting here, away. So, looking at somebody's posture, which you'll do in lower eval, one of these components is this pelvic tilt. This is where you start having fun to go sit at a mall's like food court and watch people. Because there's a whole lot of people that walk around like this. And then you're like, 5 minutes with you. And I can fix so much. Just work on a little bit of core activation will be so much better. But this pelvic tilt is really, it's changing things. So if I do a significant anterior tilt, origination of my hip flexors, my hip flexor muscles, if I tilt this forward, it's kind of pulling it down, which is shortening them somewhat. If I tilt my pelvis down, it's pulling my ischial tuberosity up on the backside. What originates on the ischial tuberosity? Hamstrings, right? So I'm actually putting them on stretch. If I have somebody who has a really tight hamstring set, to where it's pulling down on my ischial tuberosities, that's going to put a stretch into my low back. So you can look at some muscular-based back fatigue that's directly related to excessive hamstring tightness. And all of this is just pelvic tilt. Now, everything I said so far is about bilaterally shifting. What happens if I did it one way, not the other? And this is where we get some SI joint pathologies, to where if I have something that's allowed that SI joint on one side to get stuck, then I might get I'll typically get a tight hip flexor on one side and a tight hamstring on the other, because it's torqued. So one side's pulling my ischial tuberosity down, the other side's pulling my AIIS or my ASIS down. So that stabilization that we get is going to cause all kinds of issues that can give us injury presentation all over the place. So, pelvic tilt, femoral neck angle, we went into knee angle a little bit, genu varum, genu valgum on top, and it's kind of opposite with the coccyvarum versus coccyvalgum. Things that we'll have to look at when we deal with posture assessments and working with folks. Some things we can address, some things we can't so much. Good? Next class, we will be getting into the muscles that move. All of these happy, fun hip actions that we're going to have.